I would like to jump into questions, and I'm going to ask the doctors. It may be harder for us to keep track of which questions have been answered or not, but Greg and I will be kind of going back and forth in terms of questions that we're answering. So I'll just start with the first question. And I know we can't answer individual patient questions, but in general, if you could help answer some of these, that would be great. So a 34-year-old Sam is 34, has had 2 plasmacytomas on his spine. Some of the doctors are just has had radiation therapy. Some of the doctors are saying, well, you just have a plasmacytoma, and others are saying you should start treatment. What do you think when it comes to plasmacytomas? And we'll
Well,
open it to everybody.
a single plasmacytoma may be sort of an isolated thing, but you said that there were 2 plasmacytomas. I would expect if you do a bone marrow biopsy at a random location, you're going to see increased plasma cells there too. And so this would qualify as multiple myeloma and probably warrant treatment. Depending on the size of the myeloma, you said the patient had radiation therapy too. So it sounds like these were quite substantial and, could be concerning for,
But it was a normal,
possible for deeper completion.
which is the unusual.
Pardon?
It was a normal bone marrow biopsy. So that's a little more confusing. So
Yeah, but I would tend to agree that if you got plasmacytomas in 2 different spots, that sounds like multiple myeloma.
So if in theory, if you had one little clonal cell that grew and formed a plasmacytoma, but doesn't have the capability of spreading, then you shouldn't have 2 plasmacytomas. It's like lightning striking twice. So this thing has the capability of spreading, and so it probably should be treated systemically.
okay.
I really love that analogy. That's the lightning twice. That is awesome.
Yeah, it is good. Another question, one of you I know mentioned reversing the Revlimid rash, and we've had a couple questions about that. How do you do that? I think a lot of patients would want to know how to do that.
Yeah. Well, it's quite common. I can't give you the incidence, the percentage of people who get it, but it's quite common. The rash tends to be on the trunk, on the chest. Occasionally it'll go up to the face. It tends not to go out to the extremities. It can be extremely annoying. But what my standard practice is, I just stop the drug, wait for the rash to go away, and I restart it. Sometimes often at a lower dose. And I can't give any hard numbers here, but in the majority of patients, the great majority, the rash will not return, or if it does return, it's milder and I can treat it with steroids or with other standard rash type therapies. It's quite uncommon for patients with myeloma to have such a severe and problematic rash that you cannot use Revlimid or Pomalyst. And I really do everything I can to try to make it usable, because those drugs are so central to our treatment of myeloma. We cannot afford to just discard them because of a rash. So that's my standard approach. I think different centers have different approaches. I know some people, years ago, I talked to Dana-Farber about what they were doing, and they said that they just treat right through, and the rash tended to get better even if you stayed on Revlimid. This was several years ago that I had this conversation. But in general, I think probably most people stop the drug, wait for the rash to go away, and restart it, and usually you do fine. But I'd be interested in my colleagues' experience.
I do the same thing.
Yes, I second that.
Interesting. Okay, well, good to know. Greg, do you want to ask a few more questions?
Sure. One of the easier questions, we've talked a lot about Daratumumab today. Do any of you have thoughts about using Daratumumab as a monotherapy for post-stem cell maintenance?
Daratumumab is the subject of a study as maintenance therapy, but it's not. There's a SWOG cooperative group study, but it's actually what's being done is Revlimid at the standard dose plus or minus the Faspro form of Daratumumab, so the subcutaneous injection, which is a little more convenient because it takes 5 or 10 minutes to do rather than the longer infusion. But I'm not aware of data for single agent daratumumab as maintenance.
Okay.
I mean, it's an attractive idea. Perhaps better side effect, less side effects than Revlimid, because Revlimid is not without side effects when you take it for years at a time. But right now, we don't have anything to hang our hat on. Very difficult often to get. Often insurance company will catch that and they'll see the word maintenance in Revlimid and they'll immediately pull the stop handle and say, no, there's no way we're going to pay for that. But sometimes you can get paid for. Okay. Say, as an example would be someone who really had trouble with Revlimid or pomalidomide. They had trouble with Velcade and carfilzomib, but it got them through a transplant, got reduced their disease, but you don't really want to go back on those if you can avoid it. Then you could try Dara, but it can be a struggle with the insurance companies.
We have a question from Eva. It seems that that cyclophosphamide is given in France and Germany as a part of apheresis, but not here in the US. Are there studies that show the difference between the benefit and risks for patients either way?
Cyclophosphamide has minimal activity for myeloma. It might have some small effect at getting a disease in remission, but nothing close to what standard induction therapy would be with VRD, et cetera. It is very good at mobilizing stem cells, however. So in Seattle, we often use cyclophosphamide and dexamethasone for so-called chemo mobilization. You don't just give the growth factor, you give the chemotherapy 2 weeks ahead of time. I seldom do this anymore because usually we can get enough stem cells if we use growth factor, GCSF plus the plerixafor gives you extra mobilization potential. But there are some patients who you can't mobilize. And there's also some patients where we can't get them in remission. They might not have had a transplant and they become refractory to standard agents. And so I actually fall back on that combination so-called VTD PACE, where it uses thalidomide, which is kind of an older IMiD that a lot of people haven't had, and 4 chemotherapy drugs. And man, I've gotten people in remission who were refractory to everything, and then were able to go on and get a transplant. So just one anecdote, a patient we had here in New Mexico failed all her induction therapies. We got her in remission with VTD PACE. She went on to an auto transplant, and for the first time got into a CR and stayed in there for over a year. And then when she had a low-level relapse, she went on to get CAR T therapy and now has been in remission for several years. So sometimes these old-fashioned drugs can get you over the hump that you can't otherwise.
Okay. Vikas asks a question, and we don't want to get too specific, but this is an interesting case. Myeloma was detected with a kidney problem to the extent that the patient needed dialysis, but he had 0 bone involvement as seen through PET-CT. He has a 414 translocation. Does that indicate anything, or can it be okay to have no bone involvement and only in the kidney?
Yeah, that doesn't really indicate anything. That there's some patients that really don't have any bone disease, and so he's lucky, and that's great. The important things in his case, I guess, would be the genetics, the 414, and the kidney failure. But the absence of bone disease is not a good prognostic factor, but it must be great for him because he doesn't have it.
Okay.
If I could add to that, it can be kind of complex, and we often have to have these conversations with patients. Some patients have a disease where you have those plasmacytomas, and they will erode through the cortical part of the bone, the structural part, and put the patient at risk for fractures. Other patients have a disease that's very diffuse and spread out, and you don't see it on x-rays at all. But if you do a bone marrow biopsy, it's there, and it may actually progress to the point where it fills up the bone marrow space and causes the normal blood counts to drop. And regardless of whether you have that much disease in the bone marrow, you still can have an antibody being produced by the tumor that gums up the kidneys. Pretty much independent of the level of the antibody. It's just more specific to the type of antibody they're producing. So all of those things can happen independently. And that's why you need to do a thorough assessment and see how does that individual patient's disease behaves, so you know what you're trying to manage.
Here's a question from a newly diagnosed patient, and we do see this occasionally asked. Would it be possible to carry out a transplant with stem cells collected from an umbilical cord at my son's birth?
No.
Okay.
The reason is, well, there's umbilical cord transplants are have a place, but in myeloma, there's precious few that have been done. There's a lot of issues about concerns about what kind of a match that there would be, but the short answer is that no, no one would do that form of a transplant. It's a great question, but the standard type of transplant that we do in multiple myeloma, then this is important, is that we use the patient's own bone marrow, and that decreases the side effects and the complexity of the transplant dramatically. When I was trained years ago at the Hutch, when my mentor Tom Chauncey told me in terms of auto transplants versus using a patient's own marrow versus allos, where you get somebody else's marrow, even if it's a relative, that the autos, where you get your own bone marrow, those are the easy ones. And he told me those are the ones you want to do because they're easy, they're simple, patients do better. When you get someone else's bone marrow or stem cells, even if it's a relative, even if it's a matched relative, it's a very different can of worms. And in myeloma, we really have not been able to prove conclusively that getting someone else's stem cells works well and is worth the terrible side effects that you can get. So my short answer to that was no, you wouldn't want to do that. And it probably many reasons why it wouldn't be the right thing to do.
I think it's also important to understand the, I guess, the rationale of why we're doing an auto transplant versus an allo transplant, what we're trying to achieve. So for myeloma, with an auto transplant, getting your own stem cells back, it's so that you can get that high dose of chemotherapy with melphalan and have your counts, your bone marrow recover. And we're doing that by kind of giving your own stem cells back and kind of, I've heard the analogy of kind of spreading Roundup on your bone marrow and killing everything off, and then you're sprinkling the seeds back so that your garden can grow back again, versus an allo transplant when we're trying to harness the immune system of someone else to really go after and target the myeloma cells. And so the whole I guess rationale of what we're trying to achieve is very different. So I think starting from that understanding is important.
And we heard a lot about stem cell transplant today. Is it a benefit in stem cell transplant to achieve better progression-free survival? Is the benefit to achieve progression-free survival overrated in the face of no difference in overall survival?
Debatable. I mean, this is a debate, a big discussion. As I said, there is data that there is an improvement in overall survival with maintenance. And the study that we focused all our discussion on today, the IFM 2009, we're going to have a study soon that's virtually identical to it, except patients get indefinite maintenance. So 700 patients, same study, 1 year of maintenance, another 700 patients, same study, but they get indefinite maintenance. So we may see a very different result for survival and progression-free survival in the study where people get indefinite maintenance. So I think the survival benefit, it's very hard to study now because patients are living so long. It's quite difficult to see if there's a survival benefit. And there's time will tell, but I don't think it's absolutely clear that there's no survival benefit with transplant. I think we do know that if you deepen the response, if the better we are at getting rid of the myeloma, the better people do. And in general, that means it's longer before the disease comes back and they live longer.
I think the other thing to consider is that in the patients in that study that we focused on so much that didn't get the upfront transplant, 3/4 of them still got the transplant. They just got it later. So, transplant is still a very valuable tool wherever you choose to use it in the therapy.
Excellent point. That's a great point. Save it for later, rainy day.
And what that means is, and this is maybe true for all myeloma therapies, it may be that the timing and sequencing of the therapy is less important than just getting the therapy. And that's why we should all participate in clinical trials, because it's very hard to do those sequencing studies. And if we don't study everybody, it'll be a long time before we know if there is a better way to sequence drugs.
Okay. This is sort of an unfair question, but not all patients have access to the quality of care that all of you can provide. And so Cindy asks, how can she tell if she has a good local transplant center if she's not close to a major center like you, particularly during these times of COVID, when traveling to a big center is considered to be risky by a lot of patients, and it affects her decision making?
It's something I'm sure all four of us are thinking about a lot. But in a way, COVID has done us a big favor in myeloma and in cancer in general, because this thing we're using right now, Zoom, has changed everything. So you literally could, whoever you are and wherever you are, could contact Dr. Bergsigal. And I know his schedule is very busy, but you can now consult with just about anybody in the world. Your insurance may or may not pay for it, but a simple consult on Zoom, for instance, might not be totally unaffordable. And I think everyone in the myeloma community now strongly recommends that, if at all possible, myeloma patients get a second opinion at a myeloma center. So I know it still may not be possible, but the question comes from somebody who's on Zoom. So we're now doing many more consults around the Northwest and around the country. And I think it really has changed everything. You don't have to drive. You don't have to fly. Dr. Bergsigal, are you busy on Monday morning at 8?
Oh, I'm not doing anything Monday morning at 8.
There
Get
you
an
go.
appointment and I'll see you on video. Yeah, we're doing a lot of video consults, and it really has, it's so much nicer for the patients that don't have to travel all the way to see us to get our opinion.
I'm surprised that COVID hasn't come up earlier in this. We did have the whole other myeloma crowd meeting about that early during the pandemic, but maybe it goes without saying that transplants should be considered very carefully right now in the era of COVID, just because of the increased risk of complications that might happen should you contract the disease during your periods of cytopenias. And even after transplant and your neutrophils recover, there's a period of low lymphocyte count that puts you at increased risk of complications as well. So we have, twice now shut down our elective myeloma transplants, and we're doing transplants for other more emergent conditions. So I don't think that you're at a great disadvantage if your disease is well controlled to postpone it. And the bottom line of what Dr. Libby's study showed is that the timing of your transplant probably doesn't impact overall survival. So you're not at a great loss if you postpone that.
Okay. I want to stick with COVID, and I'm going to ask another unfair question and speculate. And in fact, the meeting you just referenced, Dr. Farrow, that was our very first webcast. And this is today our 12th during the era of COVID. Misty asks, with all the positive talk about vaccines for COVID, both in the UK and the US, is there any information if this is safe for a myeloma patient who's in remission? And I know that's an unfair question, but we need to speculate. I know it's on people's minds.
I'll speculate that I don't see that there'd be any greater risk with the COVID vaccine than with the flu vaccines or the other vaccines that we give to patients in remission.
And
I would second that too. I don't see why there would be increased risk if your disease is well controlled and you have an immune system that can respond. And the myeloma crowd's own data suggests that myeloma patients are increased risk from the COVID. So you might be actually wanting to put yourself up on a list, in getting that opportunity.
Okay. We have a question from CM. Dr. Farrow showed a graph that suggested that there are, in fact, patients who survive this disease. For the trend seems to be flattening the curve completely. What's the percentage of patients who are likely cured, and how can that be determined? I'm asking
You
unfair
used my name in
questions.
vain, so I,
It was asked of you.
I think so none of the graphs I showed, I think, went out very far past 4 years. And we talked about how the survival of myeloma has gotten so much better. You really need long-term perspectives on that. And it's a philosophical question, but when is somebody cured? Are they cured if they die at age 90 and you never see it come back, or if they would have lived to be 100 and it came back? So, I think as long as something goes away, it's never detectable during someone's lifetime, we're happy with that. And that certainly happens today in myeloma, but it's possibly because, the person just got it at an older age, or it was a slower growing disease. What they got at was with the graph is a little bit more sophisticated, and what the question was about the so-called plateau, a flattening of the curve. We don't always see that in myeloma, but that is an indication that over time, the rate of relapse might go down or go to zero, and you might, technically consider someone cured or very unlikely to have their disease come back. And that is definitely the holy grail of the treatment.
There's some interesting arguments. It's not really an argument, but some interesting ways of thinking about cure in myeloma. And if our treatments are allowing people to live 10 years, 12 years, 15 years, which they are, and you're an older patient, if you're in your 70s, for instance, then patients they're diagnosed with myeloma today, that are in their 70s, that it's reasonable to tell them, in my opinion, that there's a good chance that you're going to live your normal lifespan and die from something else. You'll still have myeloma when you pass away, but you're going to live your normal lifespan. You'll die with myeloma, but not from myeloma. So that's an effective cure. Some people use that as an idea of an effective cure, and I agree with that. Now, if you're 40, it's a different situation, because we don't have treatments right now that can give people 30 or 40 years of time with myeloma. So yeah, I think cures are happening if you think of it that way, that we turn it into a chronic disease and you die with it, but not from it.
Okay.
I do like one thing I heard several years ago, Bart Parlogi, who was mentioned earlier by Leaf, up on a stage, and he used to say this pretty often, is that he sort of point his fingers at myeloma doctors and say, you've got to keep talking about cure. Don't put down the cure word. We've got to keep talking about cure, because if we don't talk about it, we'll never get there. And so I really loved hearing that from him, and I think that's important. Cure is possible. Chronic disease, turning it into truly a chronic disease, is possible, and I think we will turn it into a chronic disease at a minimum.
Yep. I guess I'd say we're probably curing some patients today, but we just don't actually know who they are.
Yeah.
And I think we're optimistic that with all these things that we're, coming in the future, we'll probably cure more patients, although I don't think we don't really know who they are.
Okay. So if a patient is having a very, very good responses to cocktail chemotherapy such as VRD, and has been in a deep remission for 2 or 3 years and carries a low risk of genetic mutation, is that a patient that should consider a bone marrow transplant?
If I understood you, you said the patient is doing well. They're
doing well, no
great.
major genetic features, and everything's been working.
If you've done great with whatever treatment you got, maybe it was just Revlimid and Dex, and that's all you wanted to take, or it's all you could take, whatever treatment it is. If you've gotten into a remission and you've been stable, there's really no reason to undergo a stem cell transplant. We would want to make sure that your stem cells have been collected and that they're in storage. If for some reason that hadn't been done, it would be reasonable to do it as soon as possible. But other than that, I don't see a reason to get transplanted or to change your therapy. If it ain't broke, don't fix it.
Okay. We have another anonymous person says he was diagnosed with myeloma with no symptoms other than protein in the urine, electrophoresis in the test of the urine, a bone marrow test and DNA type, and comprehensive blood tests. However, the symptoms are more from the treatment to date than from the myeloma, which seems confusing. What should that person do?
I guess that's actually not that uncommon. I think
Yeah.
myeloma is more being diagnosed now based on blood tests when the patient feels perfectly fine. And our treatments do have side effects. And I guess the person can maybe feel relieved that, they didn't progress to get renal failure and go on hemodialysis, which, is a likely scenario if you don't get the treatment. So your life would be much worse without the treatment. But of course, you don't know that because it didn't happen to you. And I guess the patient then should work with his doctor to try and adjust the doses, tailor the doses in a way to control the disease and minimize the side effects.
That's not an uncommon thing that I hear. I'm sure that all of us here in clinic, I totally agree with Dr. Bergsigel. You may feel fine when you're diagnosed just with routine testing, but you need that treatment because untreated the disease will create mayhem. So your physician and you need to work together to make the treatment palatable and tolerable.
And that is
I know-
always a
And that's
dilemma.
actually a big advance for us is that now we're treating people earlier before they have these terrible complications. And so a wonderful thing is really happening if your disease is not symptomatic and you're getting treated. Boy, you've dodged a bullet. You have to put up with the treatment, but you've dodged a huge bullet. No broken bones, no kidney failure, no dialysis. So that's one of the ways to help you look at it while you're getting the physician to try and adjust your treatment.
A related question that I saw in the chat was, why don't we treat MGUS or smoldering myeloma? And I think that the answer is this is kind of a similar question because the answer is that the treatments have side effects, they have costs and expense. You have to go in for all your treatments, etc. And some of those conditions really can last a long time before they progress to full myeloma and cause symptoms. And again, the timing and sequence of treatment may not matter in the long run, so you might as well postpone therapy if it's not really necessary, as long as you keep an eye on it and don't let it get to the point where it's causing any significant problems.
Well, we're running a little late, so this will be the last question for the morning session. When should patients consider going from a 3-drug cocktail to a 4-drug cocktail? What are the indicators to do so?
I'd love to hear Dr. Bergsigel speak on
I
that.
was going to say, I think the premise for that is a little bit wrong, I think.
Okay.
If you're on a 3-drug cocktail and you're doing great, then you'll just stay on that, and just like we heard before. And if that therapy were to stop working, you probably would be restaged. Maybe you'd get another bone marrow biopsy, and your physician would come up with a new treatment plan based on the drugs you'd been on. You'd probably try to choose different drugs for the next regimen, something that has non-overlapping mechanisms of action. And so you wouldn't necessarily go from a 3-drug regimen and just add on a 4th drug. That we wouldn't do it that way. So I think the premise behind the question is a little mistaken.
Dr. Bergsigel, can I change the question then for you? When would you consider a 4-drug regimen as opposed to a 3-drug regimen?
Okay, well, let's talk about newly diagnosed patients. If the patient has got high-risk genetics, then I would try and start treatment with a 4-drug regimen, Daratumumab, lenalidomide, Dara RVD, if I could get the insurance company to cover that. And otherwise, if they're standard risk disease, I would use a RVD without the Daratumumab. And I guess, in the relapse setting, it would be sort of this. If someone had what I thought was high risk disease, where I was really concerned that there was a lot of subclones, a lot of heterogeneity, I would try and use, if I could, a 4-drug combination in relapse.
Well, with that, I really want to, on behalf of Jenny and on behalf of everybody that's listening in today, I just want to thank you so much for the time you gave today, for so many interesting points. I think a lot of the people who tuned in today learned a lot about this disease. It's not something to take lightly, but it's also not the end of the world. And I think you all made that very, very clear today. So I want to thank you so much. If you want to stick around off camera and answer some of the Q&As briefly, please feel free to do so, but consider your service done for today. And thank you so much for being with us.
Thank you.
Thank you.
Thanks for having
Greg.
us.
Okay, thanks. And now, as we make the bridge from the first to the second session today, I'd like to introduce Roz Height. Roz is the director of our myeloma coach program. I've been involved in myeloma for patient advocacy now for 22 plus years. I actually started before thalidomide was a thing, and one of the things that I'm so proud of with the work that we do at the Myeloma Crowd is we have an exceptional program called HealthTree, which I hope a lot of you have heard about and have taken advantage of. And the other program that I think is really remarkable, and in large part due to the program director that we have for it, is the Myeloma Coach Program, which will put you one-on-one. Either you can become a myeloma coach and help people one-on-one with your strengths and your interests, or if there are issues that you think are really important that you need more help with, you can contact the Myeloma Coach Program. You can contact Roz, and she will direct you to some really, really talented, engaged people. So with that, I'd like to turn it over to Roz.
Thank you so much, Greg. Hello, everyone. I am so grateful to get to spend a few minutes with you today. And as Greg mentioned, my name is Rosalind Height, and I'm the director of the Myeloma Coach Program with the HealthTree Foundation. And I'm also a caregiver to my husband, Richard, who was diagnosed with myeloma over 5 years ago. And like everyone, we were in utter shock and completely scared to death and overwhelmed during that time. And lucky for us, we knew Jenny and Paul Alstrom. And so I instantly called Jenny, and she shared critical information with us that helped me begin to advocate for my husband. She encouraged us to transfer his care to a myeloma specialist, which we did, and which I truly believe made all of the difference in the treatment he received and in the outcomes that he achieved. Even after we got into a routine and he began his treatment and we were embracing this new life we found ourselves in, we still felt so alone. We were in our late 30s. We had young children ages 6 to 11, and this was such foreign territory to us, as it is for everyone. We were unsure how to navigate. We were unsure of the future. We were unsure if we had a future and what it would look like and how to get there. And we slowly began getting introduced to others with myeloma, and we would just jump at the chance to talk to them. And we really appreciated the advice they would share, tips on how they navigated it. As we were preparing for stem cell transplant, we were eager for their advice and guidance. But most importantly, we just appreciated the hope that they gave us. And that's what we're hearing a lot about today, is that optimism and hope in myeloma. And that's what we truly needed, and it made a big difference. So as my husband got better and he was feeling well and we'd go to treatment, he started talking to people that he would meet in the infusion room and would like to hear their stories. And he would share that same hope with them that had helped him. And I saw what it did for him as he was able to share what he was learning and share that optimism and hope with other people. It helped him feel like he had control. He had something that he could do, even in this circumstance that he wished he wasn't in. It helped him feel like he could do something positive with it. Well, we kept in touch with Jenny and were in complete awe with what she was doing and her creation of HealthTree. And in 2018, she recognized the need for individuals to have one-on-one support. And she created the Myeloma Coach Program. And I was elated at the opportunity to become involved and jumped at the chance. And I really wanted everyone with myeloma to receive that support, guidance, and encouragement that we had received, because I had seen that it had made a difference for both my husband and I. And I had experienced firsthand both sides, the benefit of giving that support and also of receiving that support. So I was so excited to become part of this program. So how does it work? So the coach program is a peer-to-peer program that offers one-to-one individual personalized support. Myeloma patients or caregivers volunteer their time as a coach to turn around and share what they've learned with other people. And all of our coaches truly care. They want to make it easier for other people. They want to lighten their journey. They want to share what they've learned to help others navigate it easier. So coaches, as they register, they indicate the areas that they've gained experience in, whether they've had a stem cell transplant or had experience with CAR T therapy, navigated short and long-term disability, Medicare, insurance issues, the things they've learned in maintaining their physical health and nutrition, or their mental and emotional health. So they include all of those in a profile along with their picture, and those are posted on our website. The best thing about this is everyone has something to offer. It's your own personalized strengths and interests you bring to the table to be able to share with other people. And most importantly, they bring that shared experience, the ability to personally relate to the feelings that you have at diagnosis or when you relapse, or the excitement of when you reach remission. Those profiles are listed on our website. And individuals who are interested in working with the coach then can simply register on our website and view all of the coach's profiles and choose someone that they feel would be a good fit for them. And all of our connections and communications are completed directly on our website. If you're not someone that uses a computer, you can still participate. Just email us and I will help you, and we can personally connect you with someone. But everything goes through the website, which makes it easy. Once a patient finds someone they want to connect with, they can do it all through the website. They request a coach, or they can initiate communications all directly there. And the best part is patients and coaches can communicate in the best way that works for them. So whether it's by phone, email, video chat, or hopefully someday again in person, but you can set that up according to your preferences and what works best for you. And some people, they may need to talk to a coach once or twice. Other people may have ongoing questions and keep in touch every few months. And many in our program become friends and they keep in contact. One thing to note too is you can work with more than one coach, because all the coaches have such different experience, and depending on what your questions are or your needs, you can request multiple coaches to meet all of the needs that you have. So many of the coaches, they report the same thing that my husband experienced, that it really helps them to be able to share their experience. It helps them to know that they're making a difference. And they really also appreciate their association with the HealthTree Foundation and the resources and education that's available. We offer initial training to all the coaches, and then also ongoing training each quarter. And we have a yearly coach summit as well. So there's lots of opportunities to network and learn from other coaches and take advantage of educational opportunities. One of our coaches, Jen, shared, "Volunteering gives me the opportunity to share my knowledge and personal experience with others. It gives me a sense of purpose." Another coach shared that she became a coach to stay connected to resources that allowed her to understand her disease. And she says, "When you help other people, it just makes you feel good." Patients in our program really express that they value the shared experience, having someone help them find resources and answers to their questions. As we say, we all know it's so overwhelming. And so just having someone that you can call to talk you through it, it really makes a difference. One of our patients was recently recovering from her stem cell transplant, and it was taking longer than she had hoped, and she was getting discouraged. And she was also looking forward to beginning a new treatment, Darzalex Faspro, and she was worried about that. So I connected her with several coaches that had experience in those areas, and she talked to them to get varying perspectives. And she said, "It's a good feeling to not be alone and isolated on this journey. Everyone has been open and welcoming. Sharing our stories definitely lightens the burden." Another patient shared, "I talked to my coaches today and they were extremely helpful. They eased some of my anxiety about stem cell transplants. I'm so glad I found them on your site. They are doing a great job. Thank you for your website. People that coach are really needed." And truly, we couldn't agree more. We really feel that personalized support is needed, and we're excited to offer this program. We have over 150 coaches from all over the country and even some internationally as well. And we have over 350 patients in the program who are participating as well. So no matter where you are in your myeloma journey, whether you're newly diagnosed or you're further down the road, if you find yourself wanting to talk to someone who can relate, who can understand, who could help you navigate, or just to know that you're not alone, I hope you'll connect with us and visit our website, myelomacoach.org. If you have questions about the program today, feel free to enter those in the Q&A, and I'd be happy to answer those. And our goal is that no one has to face myeloma alone. And we hope to hear from you. Thank you so much, Greg.